Hi, everyone, and welcome to today's webinar on elevating the role of malnutrition in your hospital. My name is Christina Badaracco. I work at Avalier Health. Okay, great. Here's our introductory slide. Thank you all for joining us today. So briefly, I will remind everybody that your lines are muted. If you do have any technical issues, please use the chat function within WebEx to let us know. And you can also send questions in via the chat function throughout the event, and we'll compile those and pose them to speakers at the end of the webinar. So here is an agenda for today. I'm offering introductory remarks now, and then we'll feature our speaker, Christy McFadden, and we'll end with our Q&A session. I will also note we did have a last-minute cancellation with our second speaker, but we still very much look forward to a robust conversation with our first speaker, who is Christy McFadden. So I will introduce her. So Christy is a registered dietitian nutritionist with over 14 years of clinical experience. Until 5 months ago, she led a large team of RDNs in a large healthcare system. Her leadership focus was on quality improvement efforts in identifying, preventing, and treating malnutrition. Her team was able to submit 3 abstracts around their quality projects in the September 2019 MQii supplemental issue of the Journal of the Academy of Nutrition and Dietetics. Her leadership team and efforts were also featured in an article in the supplement. Because of their because of their high impact visible quality work, Christy was recently recruited to join the Corporate Quality Safety and Patient Experience team as a quality improvement specialist at Spectrum Health. She's also been invited to speak at a variety of conferences and events across the state of Michigan, other states, and Mexico. She's a simulation instructor at Michigan State University College of Human Medicine and was previously an adjunct faculty member at Aquinas College. And with that, I will turn it over to Christy.
Thank you, and thanks for having me here today. I'm excited to talk about this because I've been passionate about this topic for years, and I'm excited to share with all of you the story that we have gone through as dietitians at Spectrum Health and improving care for our patients who are malnourished with really a focused effort in the last 4 years or so. So I'll start with just a few kind of bullet points of takeaways to tune into during this presentation. One is knowing your audience, which we always hear and we often kind of attribute to any kind of presentation, but it's not just giving a PowerPoint presentation or something like this sort of format that we're doing right now, but anytime that you have a chance to speak with executives or nursing managers or clinicians that are working side by side with you, understanding their perspective on things and then being able to relate the information you want them to understand in a way that makes sense to them. So we'll talk about that. And then also data. Data is always something that we really want to have. It helps us tell a good story, and really I think through this process, what I really learned to understand is getting good quality data and the data that we really want and excluding the data that we don't want. And that sometimes can be a challenge. So we've certainly had our own challenges with that. And then always seeking opportunities to engage colleagues in a variety of venues and speaking about whatever, if it's malnutrition or whatever really dietitian or nutrition related issue that you have. You never really know who might be in the room or who you might come in contact with that can help you and all of a sudden break open a barrier that you maybe have been struggling with. So I think that's another key point. So a little bit about us. We are Spectrum Health, which is one of the largest health systems in Michigan. We're in Grand Rapids, so we're on the west side of Michigan, a couple hours away from Detroit. And this is a little picture. The tall blue building in the middle is our children's hospital, and we have one of the largest NICUs. I think we have the largest NICU in the state, actually. And we have the Meyer Heart Center. If any of you are familiar with the Fred Meyer grocery stores, that's who supports this community because that's kind of where they started and that's where they live. And we have a couple other major hospitals in the city of Grand Rapids, that's Butterworth and Blodgett. So whenever I talk about Grand Rapids hospitals, that's what I'm referring to. And then we have regional hospitals, as many of you probably do as well, where there's community hospitals around the state of Michigan that are also a part of Spectrum Health. And then we also have continuing care hospitals, and we have a unique hospital system, which is Spectrum Health Lakeland. And Lakeland is a hospital system that has done some incredible things and has really great innovative skills, I guess. And so we partner with them, and they are part of the Spectrum Health family, but it's kind of a unique relationship where we're kind of co-leaders together. So first I want to just talk about knowing your audience and knowing people. When I first started as a quality improvement specialist after being in the MNT department for 14 years, one of the first things that was given to me was a list of people to go and sit down with for 30 minutes and just get to know them or meet and greet. So I found this incredibly valuable, and I would recommend this to any clinician that is trying to do any kind of quality improvement projects, particularly around malnutrition or something that maybe not everybody is always aware of, and that's kind of what you're trying to do, is get people aware of it and engaged in that work and taking care of those patients. So I think that has been profoundly impactful, and setting up just time, people are usually generally open to that, just trying to get to know, what are you working on, here's what I'm working on, how can we collaborate, who do I know that I might be able to connect you to, who do you know that might have some insight on this thing that I would like to investigate. And then another key thing is mentoring relationships. So, all of this is just about networking, and some people don't really know how to get started with that. And it's not just, I'm going to walk up to you and talk to you in the hallway and introduce myself, although that's effective sometimes as well. But it can be something even more official like this, where you might reach out to somebody that you would like to have as a mentor. And so I, in fact, had my first mentor was the Chief Nursing Officer and Vice President of Clinical Operations. I'm going down to the kind of the bottom of the slide here. And she was my professional mentor and really created a lot of opportunities for us to get our malnutrition improvement projects off the ground. So I'll talk a little bit about that more later, but that was just a key relationship that I think we wouldn't have gotten as far without something like that. And the mentoring relationship is unique, where you can suggest that, you want help on these specific things, or you want this out of this relationship, so that it's time effective for both of you, even for somebody with that such importance in the organization. But at the same time, you kind of get to know them a little bit, and they really understand the work that you're doing, because you have more of a routine visit with them versus just a meet and greet. So our team we first reached out to our coding teams because we wanted to understand, the very first thing we really wanted to work on was, we as dietitians are making this diagnosis of malnutrition, and we wanted to make sure that the physicians understood what that meant, understood that we were the experts to do that, and that they would also support the documentation that we were documenting. So one of the first things we wanted to understand was, what did the coding team see, and what could we learn from them, and what could they even learn from us about how we could collaborate and work on physician documentation. And we found a really close ally working with them, because we had no idea that they were actually working on something very similar, because they wanted to decrease the number of queries that they had to propose to providers. So when teams like your CDI coding documentation teams, we have a team of nurses, and we all have these teams of nurses who go through charts and code as the patient is in the hospital, and then if they notice certain things, they can query the physician and say, it looks like the documentation is supporting a diagnosis of malnutrition, do you agree? So they're not really saying, you need to do this, they're saying, is this something that should be coded or not? So it's a very concise language to make sure they're not pushing that, but at the same time asking, we want to make sure we're coding correctly and not coding incorrectly. So one of the top two most queried diagnoses they had was malnutrition. Number one was congestive heart failure, just FYI, because I would wonder that if I heard something about what was number two. So, and that's such a common diagnosis and there's so many different terminologies for that word, so that made sense to us. So they were really happy to help with this because that wasted a lot of their time, or at least they could be much more efficient if they did not have to query for those diagnoses. So they were looking at our notes, seeing this, and then querying the physician. So we worked together and helped spread awareness and improve that documentation. And then they also came up with a lot of great data for us to tie the first story that we could tell about malnutrition at Spectrum Health and how many times they might see this in the chart, or how many times they do query a physician about this. And then over time, as we made improvements, we could see those queries go down. So like I said, my mentor, who was the chief nursing operator, chief of nursing and the VP of operations, she helped us get some really key presentations scheduled so that we could get in front of a lot of people who could help support the work we wanted to do and raise the awareness that this is important work to do. So our kickoff presentation was with the Clinical Quality and Safety Committee. And this committee really leads the quality work within our organization. And I say that it was memorable there because since I've actually joined that team, that quality and safety team, I just joined 5 months ago, and this presentation was 3.5 years ago now. Several people had remembered this presentation. So I think part of the reason is because we did have not just the content, but the way we presented it. So as you see on the right, this is one of the first slides that we presented was this quote by Charles Butterworth, and I'll let you read it, but he had published a study in 1974 and said, we have a problem with our patients being malnourished in the hospital, and he called it the skeleton in the hospital closet. So that kind of puts a picture in your mind, and it alerts people that there's a major problem that we need to pay attention to here. So I think those kind of phrases are actually really powerful, and making that memorable is important because people see so much information every day and different presentations and so many meetings that they go to, and in order to get something to stick, it really has to be profound like this and create a picture in the mind. So then after that, we were given support mostly by that chief of nursing, who helped us set up a malnutrition steering committee. So on that committee, we invited many physicians in different areas. We had nurses, allied health clinicians, including like physical therapy and care management. We had quality improvement specialists, informatics, people from the coding team. We had a research nurse. So we really had a robust, well, I shouldn't say had, we have still this robust malnutrition steering committee who works to kind of guide the action plan for the quality work of malnutrition at Spectrum. So again, just providing a consistent theme, I think that's important, and catchy phrases can also help. We have a vice president here who is the vice president of Quality and Safety and Patient Experience department that I'm in now. And another one that I presented at a different time, she said she always remembers when I said everybody needs nutrition, meaning every patient population that we work with, nutrition is a big deal. We all know this, but it's, again, helpful to understand your audience because they're not thinking necessarily about that. And it's our job, I believe, to give them that information and help them understand that. So we did a lot of improvement work just right off the bat with that committee, with that malnutrition steering committee. In January of 2017, we had a policy for dietitians where we could write orders, which we weren't really doing to our full capacity prior to that. We weren't allowed to order supplements and things like that without a physician approval, which many of you may still deal with that. We all found that ridiculous, of course, and most of the physicians did as well. But once we were cleared of that, we were able to get that approved by all the medical executive committees across all the hospitals in our system. So it was kind of a process, but it was very much needed, and everybody recognized that. And then in November of 2017, we switched electronic health records, and during that process, there were a lot of reviews of policies and privileges. So we were actually added to the problem list policy, meaning that dietitians now at Spectrum Health have the ability to add malnutrition diagnoses to the problem list. So this is not where they get coded and all of that from. That happens from the provider note, but the problem list ensures that every place that that patient goes that is on our electronic health system, so if they're on our record, they can go to their primary care physician, a specialist, at a hospital admission, and that diagnosis will be there. So it should be addressed everywhere that they go. Now, whether or not it is, I don't know. That's probably a quality improvement project to work on. So another thing is because we also train dietitians in diagnosing malnutrition and doing the physical assessment. And this is something I think is ongoing. We're always training new dietitians, but at the same time, we all kind of felt like if we're going to do all this quality improvement and ask our other clinicians to do this work, back in 2016 and 17, we really felt like we needed to enhance our own skills. So we continuously work on that. So when we did switch electronic health records, we also added a few other things that would help us with our quality initiatives and focus on malnutrition. So we added the validated malnutrition screening tool that has to be completed by nursing within 12 hours of admission, and there's a hard stop for that. And then they're supposed to, at that point, if the score is 2 or above, consult a dietitian. We also improved our own documentation and how we could clearly state what findings we found in the patient that meet the criteria for malnutrition and what diagnosis we would make. And then that information was pulled into a malnutrition note that was then routed to providers to co-sign. So that was the key point to get it coded, was because it had to be signed by the provider. So that works really well. We have almost 100% compliance with that, and it's really just striving to help other people understand this is the situation of this patient. This is the clinical scenario of this patient, the clinical condition, and we all need to support that. And so when we're all aware of that and it's documented well in the chart, everybody can pitch in to help support that patient for those reasons. So the next thing was we really wanted, those took a while and those were great projects and great improvements, but we really wanted to have good data on what does malnutrition look like in our facilities and in our organization. And that we knew would help drive some more quality improvement projects, but also help our executive teams and our leadership teams understand the importance of this and what we might want to do to take better care of these patients. So we conducted a prevalence study where on one day, we'll go through this chart here, on one day in March in 2018, we assessed every single patient that was in the hospital in the Grand Rapids hospitals. That's 2 acute care hospitals. And we excluded some patients if they were on hospice, if they were OB patients, if they were in comfort care or observation status, and children who are under 18 years old. So we assessed 618 patients. Now, some of those we had already assessed because we were already following them. We just had to get data on those. And this was where I feel like the quality team really helped us a lot in making sure that we collected consistent, clear data, which I think is a huge part that was helpful to us and allowed us to do good analysis on it. And then we had our information services team pull that data out of our electronic health record, and they were only able to find 582 patients, and there's a long reason for that. I think there's multiple reasons for that, but we never can quite get exactly the same ones, even though we've worked really hard to do that. So we came pretty close, and out of those 582, we had 122 patients that the dietitian diagnosed with malnutrition. So that was a 21% prevalence rate at our main hospitals. And what's published in the research is 30 to 50%. So we've had a lot of conversations and discussions about why that might be. We certainly do not believe that patients in Grand Rapids are any healthier or any less malnourished than other large areas similar to ours. And so I think probably a lot of this is, could it be that the published research is maybe more high-risk patients, or I don't know if how many people really do these full hospital prevalence studies where they look at every single patient. Sometimes you might just pick a few floors and extrapolate that data. So this is really kind of pure data, and we did it again the following year and got very similar results. So if we did it again in the following years, would we get the same? I'm not sure. Again, we're still trying to enhance everybody's skills at diagnosing malnutrition, and we certainly notice it's difficult when patients are in the ICU sometimes. It's difficult when patients, you can't get a good history on them, and it's also difficult with very obese patients. I'm sure many of you experienced something similar. So that could be part of it as well. And then we also looked at some of the other gaps, like our malnutrition screening tool. If it was greater than 2 in those with malnutrition, only 41% of the time that was true. So if we diagnosed them with malnutrition, how well were they screening out, and how well was that MST working upon admission? And 10 of them were not completed at all on malnourished patients, which actually we didn't think that was too bad. I mean, we certainly have some patients who can't answer the questions that are on the MST, so we thought that wasn't. So our nurses are completing it. And we wonder sometimes, too, more education on how to ask those questions well and dig deeper based on certain answers can be helpful. And then we also looked at was the dietitian consulted? So even if the MST was greater than 2, did they actually consult the dietitian, which was an important part of the process. And 34% of the time it was not. So that was a concern to us. So they're doing the MST, but what are they doing about it? And then we did this in our regional hospitals as well. So outside of Grand Rapids, about 6 months later, we had to do it a little bit differently because the populations or the census in those hospitals are a lot smaller. But we did assess patients every Wednesday until at least 50 patients were completed. So that was the way we could at least get a pretty good N number in each hospital. So determining the prevalence, we had 329 patients assessed, and 42 were diagnosed with malnutrition by the RD. So that was a 13% prevalence rate, but by hospital that ranged really between 0 and 30%. And then again, the MST was very well completed as far as most patients. I think it was like 98% of the patients in the regional hospitals did have the MST completed, but only 17 out of the 42 that were diagnosed with malnutrition had an MST over 2. And that was only 40% of the patients that were malnourished. And then 55% of those that were malnourished did not have a consult in for a dietitian to see them. So a nutrition consult is a consult to a dietitian. So definitely some areas of opportunity there, and a way that we would like to improve, do some more quality improvement around those things. So once we had good data, it was really easy to start spreading our message everywhere. We really wanted to engage as many clinicians and leaders as we could. So we were asked to speak in front of several different groups, like the Nurse Managers Council, Central Shared Leadership. We have magnet nursing certification, so we talked to a magnet group. We've really done probably 30 to 50 presentations around this. And having that good data really helps you put a good presentation together. And then when people see your presentation, they'll often say, well, can you come and talk to this group as well? So that's been really helpful to spread the word. And so we also take great advantage of Malnutrition Awareness Week every year. So in September, that 1 week that's Malnutrition Awareness Week, we've done some kind of event every year. We've tried to do different things for nursing especially. We've done webinars and events. And it's kind of hard to get them to do those kinds of things. So it's hard to get that many nurses in a space of time that they can commit to that. And even if you offer CEUs, we found that it was difficult. So what we did last year in 2018 was we had flyers that were made, again, knowing your audience. We had a flyer made for providers, and we had a flyer made for nursing. And we actually had a flyer for dietitians for them, points that they should focus on. And then we had another flyer for any other kind of clinician that the dietitians come in contact with every day. And we encouraged each dietitian to use their own voice to spread the word and kind of boots on the ground fashion, go out and talk to their teams, talk on rounds and huddles and any other kind of areas where they have a venue to add a 5-minute heads up on, hey, it's Malnutrition Awareness Week, this is what we're doing, this is what we would like you to know. And we actually did a competition where we gave all the dietitians those flyers, and then we gave them red pens that they could give out to anybody that they talked to and gave a flyer to, and they would just have quick one-on-one conversations, like a 5-minute, hey, you know, did you know this is what we're looking at when we look for malnutrition? This is a good way to ask about the malnutrition screening tool. And then they would give them a red pen, and then they would sign their name that they were educated on this. And then we gathered all of that, and we gave prizes to dietitians who spoke to the most clinicians. And we had one dietitian who spoke to over 100 nurses and physicians in 1 week. So that was really impactful. And of course, sometimes you can get a lot of them at once if you go to a huddle. But we gave the red pens to signify stop using albumin as an indicator for malnutrition. That was one big message last year. And stop and think about nutrition for your patient. So we also put this tile, it's called a tile, on our interweb page where that sat for a couple days to help people understand and just kind of see what we're talking about for Malnutrition Awareness Week. So again, using a variety of outlets, pretty much any meeting I ever go to, if I have a chance and I think it connects or relates in even the smallest way, I will bring up this effort and get it in front of people. And honestly, people really want to know, and they really are interested, and we can't make assumptions about anybody knowing something before we tell them. And then we also provide education. So on our own intraweb page, we have a malnutrition page, and we dedicate that for education. And we have a variety of things there. We have those flyers that we handed out, for example, but we also have links to CEUs that nurses can get, that providers can look at, and we just provide ongoing education there. And then a final note here is telling patient stories. When you hear stories about, like, for example, we had one story that we told often about a patient that was on tube feedings, and the dietitian believed they were well nourished. There were no signs of malnutrition. They had been on long-term tube feedings, but they were facing surgery, and their albumin level was low. I can't remember what it was, like under 3. And the surgeons decided to delay the surgery until they were well nourished based on the albumin. So stories like that, I think, really had an impact, especially on nursing, but then sometimes in some provider spaces as well. And talking about knowing, again, it's knowing your audience and knowing what kind of information will really hit home for them. And then also, I think it's important to go back to all those groups, anybody that you have engaged with. Particularly for us, it's our Malnutrition Steering Committee. We engage them every time we have Malnutrition Awareness Week and let them know what our efforts are and ask them if they can help, spread some flyers. We have a hospitalist here that's always willing to spread the flyers to his teams. And the coding team, from the very beginning, they've always been appreciative of those materials that we make to spread that message. So always going back to them and just giving them an update. After we did a prevalence study, we'd share the data with them first, and then maybe take that show on the road to other areas. So continually updating people who are contributors and making your team a large team and an organizational team so that you consistently have buy-in from them. Another team that I think is really underutilized is our information services and our data insights teams, and how we can leverage their skills to help us tell the important stories around our quality improvement projects here. And then anybody who might be a mentor or people in informatics have been really engaged here, so I think there's a lot of opportunity to spread this far and wide. So we also give them information. Again, we don't necessarily ask them to come up with their own thing, and we might ask them what do the people on your teams like to hear about, and that might be a good place to start. Asking lots of questions is always helpful, and then thanking them for their contributions always. So this is an infographic that we had made based on our Malnutrition Awareness Week last year, and all the conversations that we had, all the engagement that we were able to accomplish, and then just some other key findings were some points that we realized in those conversations. You learn a lot from the residents and from the nurses themselves, and that can also help drive some other quality improvement projects as well. So I have here a few slides for examples of after we had done all of this work. It was really great timing when the MQii team was requesting abstracts to submit for this JAND supplement that came out in September. So we were really excited to be able to submit 3 abstracts based on the quality work that we have been doing. So pretty much everything I've covered today was published, and there are some brief stories or abstracts that are in that supplement if you'd like to read any details, and feel free to reach out to me with questions. But we did talk about increasing the visibility of the dietitian, determining our prevalence in our hospitals, and also raising awareness of malnutrition every year. And then my colleague, Angela Paul, and I were both interviewed for this article that was also in that supplement. So we were really happy to, and again today, just share some of the experience that we've had. There's definitely some ups and downs throughout this whole process. Sometimes you feel like you're really hitting a wall and can't break through. And like I said, so you never know who you might talk to the next day that can break that open. And it's always exciting it's really exciting to get data and get good evidence to tell your story. So I think just for next steps of where we're looking to go with our quality improvement projects in the future, now that I am a quality improvement specialist at Spectrum Health, I have a little bit greater scope that I can, that I can help drive this forward. So one of the things we've been working on is becoming a Tier 1 member of MQii so that that data can also drive our improvement projects. And we're still in the process of this. It's actually multiple steps that our organization requires for us to go through that. And then also engaging data scientists. If you have data scientists in your organization, I'm sure you do. Sometimes dietitians, I think, are not connected to those things, or some of those options that are out there. But data scientists can really look at a large amount of data at once and kind of give you different perspectives on it and maybe different angles to look at things, and that might drive different quality improvement projects. And then one of the other things that I know the dietitians have discussed and talked about as the future is discharge planning. That's kind of a gap for lots of patients in a lot of different conditions right now, but if we can get ahead of that and help patients once they get home. So it might be improving education materials or how we talk to patients. Again, knowing your audience and knowing what they know and understanding their situations can help them at home, help them help themselves. And then increasing our outpatient dietitian referrals and connecting our inpatient dietitians to our outpatient dietitians and how we can make that a smooth process for a patient. Our recommendations always front and center in discharge instructions. And then connecting to community resources. We've actually done quite a bit of work on that, especially with our diet technicians have helped with a lot of that because they have a lot of these conversations with patients as they're educating them on heart-healthy diet or controlling blood sugar and those kinds of things. And then we also have done some research that we're really just getting started with on having patients have meals at home. So we've tied patients that have congestive heart failure and malnutrition, and we're doing a study on what it looks like to feed them at home, and does that reduce readmissions and provide better outcomes.
Thank you.
So I think that's it, if there's any questions.
Great. thank you so much, Christy, for sharing all of your experiences there. It's great to hear that you've been able to raise awareness to that extent and get so many other people throughout your hospital on board. So we really appreciated hearing your story. So we are going to move into our question and answer session. Again, lines are muted for all attendees, so please do type in any questions in the Q&A section on your WebEx window, and we can take those over the remainder of today's call. So for now, let's see, how about to start, how were you able to convince non-RDs of the need for dietitians to be able to write orders and the benefits that could be realized if they did?
Actually, it was pretty easy for us because the physicians were, I don't know if tired of is too strong, but they were tired of co-signing all of our orders for that. And for something, for us, it was especially the supplements, and the physicians were, I think everybody has this question, if a patient can buy it over the counter, why does the physician need to order it in the hospital? And we're talking about something that is safe to consume. So we really kind of took it from that angle and said, we provided some evidence that dietitians are the ones who are the expert in determining what diet order a patient should have, what supplements they should have, and tube feeding formula they should choose. And a lot of the physicians are often relieved because they don't know all those details all the time. There were some limitations, like we would not advance somebody from a pureed diet to a general diet or something like that. Those were obvious. We didn't even give ourselves the privilege to do that unless there was an advanced diet is tolerated ordered alongside it.
Yeah. Okay, great. And then I think it was on slide 8, how did you actually improve the RDN malnutrition documentation that you mentioned? Since different RDs, even in the same department, have different styles, it must be a challenge to standardize notes into a malnutrition note for physicians.
Yes, that's a great question. We did have, originally in our intervention section, we would write out all the criteria that the patient met and then the diagnosis that we would make, and the physicians would look at that. And so we ended up building more of like I think originally we had like radio buttons, but now we have a flow sheet format where you can select like temporal wasting and maybe some kind of fat loss in a particular location in the body. And you could select all the criteria that you needed to fill in, and then you could select the diagnosis that you made, let's say moderate malnutrition, and then all of that information behind the scenes, once that was filed, once the dietitian was completed that note, it would go in the background. All of that information would flow into a malnutrition note that the physician could co-sign, and then it would pop up for them as, would you like to co-sign this note?
Oh. Okay, great, thank you.
So instead of a lot of text writing and filling in text boxes, we made it very clickable and making lists for selections. That's what really improved it and made it a lot faster, too.
Yeah, absolutely. That definitely makes sense. Thank you. So you also, when you were talking about your prevalence study, mentioned that it's difficult to assess malnutrition prevalence among obese and other patient groups. How do you train RDs, or I guess at the time, how did you, in those complicated cases and then convey to physicians?
Yeah, so we actually partnered with a university here that has a dietetics program and a master's program, a clinical master's program. And so we have been actually working with them, and since I haven't been in that role in a couple months, I'm not sure where it stands, but we requested for them to do a competency checklist, and they have already done, they have a simulation lab actually with real patients, so they're standardized patients, so they're actors, but you can go over to their simulation lab and the dietitians can learn how to interview a patient, how to do a physical exam, and then there's a coach at the same time that's coaching that And so I've asked them to come in and train the dietitians in the hospital, so we kind of worked that out legally, and which is actually a very easy thing to do. We thought it would be a lot harder because anytime you do contracts with a university or other business or something, it's usually complicated. But for the purpose of education, it was actually very easy to get approved, so that the expertise of their departments could come in and coach our dietitians and then kind of check off their competency on the different areas of the physical assessment and point out any gaps that we could address as a department or as a team.
Okay, great, thank you. Let's see, we have a couple more here. Okay, so you mentioned a malnutrition webpage that you had set up before. Do you have any means of assessing who is accessing that webpage that you mentioned creating, and how they're using, to what extent they're using the resources you're providing?
I do not. That would be a great thing to have, but I don't currently have that.
Okay. Okay, well, let's see. I have another question I guess I think a lot of people might like to hear. Can you talk a little bit more about why you decided to submit to the JANS supplement about malnutrition this year, and then also how you decided on the topics that you focused on? I think you listed 3 different abstracts.
Yeah, I thought it was a great opportunity to get the great work that my team had done out and available for others to view, because I feel like this has been such a huge focus of our team for so many years, and it felt like a reward to be able to spread that knowledge and kind of pat ourselves on the back and say, hey, look, we did something worth publishing. And I think that helps boost the morale of the team, and then also helps us to continue our work. I mean, we can tell our executives or anybody else who we may ask for support to continue quality improvement or to, improve the care of our patients who are malnourished. I think when you can tell them that you've been published and that Spectrum Health is the name is out there, that we've done this work, I think that's really powerful.
Yeah, thank you. I definitely agree with that, and I would say I think a lot of other hospitals and systems that are participating in MQii are finding similar things. So that's definitely a big component of what I think the value added of being an MQii can be. We're excited to work with everybody on that. So one other question I'll ask, and again to the audience, if you'd like to submit anything else, we do have a little more time, is a question about when you were talking about potential future plans for improvement around discharge planning, and you mentioned some of your diet techs were compiling a resource about community resources. Can you talk at all about how they're assembling that resource and how you know what are most evidence-based? And then I guess kind of a part 2, how you maintain connections with those resources when you're focusing mostly on inpatient care.
Yeah, I think we started that work, and I do think it's a challenge, especially we had the diet techs really working hard on that, and they were really focused on that, and we're really happy to contribute to the malnutrition work that I think they knew our whole department was really focused on, but they didn't know exactly what their role was all the time with that, because they didn't necessarily get to follow those patients because the dietitians were always following them. So they found that their way to contribute was to help connect those patients with our community. Yeah, and so we did, what they would do is they would connect with some of the resources that were in our community. So whether it would be Meals on Wheels, or we have, various programs that might, maybe even food pantries, or sometimes it would even be farmers markets types of avenues, and they would just compile resources to be able to give to patients. And we went through the whole process of, does this need to be approved by our education council, or which of these materials are appropriate for patient-facing material. So we did do kind of a deep dive on those things as far as evidence-based. But other than that, I mean, it does take some legwork to stay connected with those organizations because, yeah, like you said, when you're in the day-to-day of inpatient care, you don't have time to necessarily connect with all of them. But I think it's reasonable to maybe reassess every 6 months or so.
Okay, thank you. So I think that's it for the questions we've gotten today. For the audience, if you do think of any other questions, you are welcome to email the malnutritionquality@avalier.com inbox, and then we can reach out to Christy to follow up. So with that, Christy, I thank you so much for your time today. That was a really great conversation, and we really appreciate your time today. There will be a recording available within a few days of the event on the MQii website, and we will send to everybody on the call a copy of the slides, the recording, and information for the continuing education unit shortly after the presentation. So that's all we have for today. Thank you all for your time.